Okay. Um, Welcome to this session of e-learning. I'm Dr. Premsekar, an interventional pediatric cardiologist based in Chennai, India, from where this presentation comes to you on the 7th of January 2020 with a bouquet of wishes for a very happy new year. My brief today is to talk on atrial septal defect and over the next 30 minutes, my presentation will confine to the signs, symptoms, history, and investigation of atrial septal defect. To keep this presentation um, interesting, I'll be quizzing you in between. So be ready with your answers in the chat box, and that way it will keep us all engaged and more interesting. So moving on to the first slide. ASD is the third most common of all congenital heart disease, accounting for almost 6 to 10% of all the congenital heart disease put together, and with an incidence of 1 in every 1,500 live births. So, being such a common lesion, this is one lesion that you as pediatric cardiologists will be encountering quite frequently all through the span of your career. And despite being a simple hole in the heart, simplest of the holes in the heart, this lesion will cause quite a lot of intrigue and pose challenges to you throughout your career, especially considering the fact that now the management of most of these effects have come under the purview of the pediatric cardiologist. Um, so I would want to ask you if there are any participants ready to answer. What is the most common of all congenital heart disease? Bicuspid aortic valve. That's correct. Very good. So we got a couple of answers, and they are all correct. Bicuspid aortic valve being the most common. And can you tell me the second most common of all congenital heart disease? VSD is not quite correct. Okay, the second being mitral valve prolapse. So bicuspid valve first, yes, Abhay is quite right. Mitral valve prolapse is the second most common. ASD is the third most common of all congenital heart disease. So this is one lesion being so common, you have to have a very healthy respect and not to be treated very lightly. Female to male ratio of 2:1, and inheritance is generally considered to be multifactorial, with a risk of occurrence in first degree relatives and progeny being 2.5%. But also autosomal dominant inheritance has been reported in isolated ASDs associated with severe AV conduction disturbance and in Holt-Oram syndrome. Autosomal recessive has also been recorded in Ellis-Van Creveld syndrome and TAR syndrome, thrombocytopenia absent radius. So to understand the morphology of the septal defect, it's mandatory to be thorough with the embryology of the atrial septal formation. And so we'll be spending some time on this slide and the next to make us thorough with the embryology of the atrial septal formation. So around 28 days of gestation, a thin septum grows down from the roof of the common atrium that you see here. bifurcating the common atrium into left and right atrium. And as it grows down towards the endocardial cushions, it leaves a small gap here, which is called the ostium primum, meaning hole number 1. And this ostium primum is essential for to maintain the right to left interatrial shunt that sustains the fetal circulation. So, but this ostium primum defect does not stay permanent. As mesenchymal cells migrate from the septum primum down to the endocardial cushions, this begins to close. And as it begins to close, you have multiple small perforations appearing in the upper part of the septum primum due to cell death and apoptosis, which then aggregate to form the secondum, ostium secundum, meaning hole number 2. So as the ostium primum closes, the ostium primum takes over the role of the maintaining the right to left mandatory interatrial shunt, which sustains the fetal circulation. And as this happens, invagination of the roof of the atrial wall adjacent to the septum primum towards its right forms a thicker and muscular septum which grows downward, which is called the septum secundum. And this again covers the septum primum entirely with a deficit in its part in the region of the fossa ovalis called the foramen ovale. So what you see here, and this is established by 2 months of gestation. So here is a recap of what we have just seen. In if you look at this, you have the septum primum growing down from the roof of the common atrium towards the endocardial cushions, and as a small defect down here, which is the ostium primum. And as the ostium primum starts closing, you have multiple small holes appearing in the upper part of the septum primum, which are then aggregate to form the ostium secundum. And when this is done, you have the atrial roof invaginating down to form the septum secundum, which covers the thinner septum primum to form a flap valve, because there is a deficiency here in the middle part and the region of the fossa ovalis. So if you look here, the septum primum being very thin and kind of the flap valve of the foramen ovale, and this antenatally being because the RA pressure is higher, the blood is able to push the flap valve away to the left and flow shunt right to left. And postnatally, when the left atrial pressure increases after birth, this flap valve opposes to the septum secundum, and endothelialization causes termination of the interatrial shunt, in effect separating the left atrium and the right atrium completely. Any factor that delays this opposition of the septum primum to the septum secundum would result in a patent foramen ovale. And that patent foramen ovale is a condition which is quite common in the adults. Up to 25 to 30% of adult population have a patent foramen ovale. So if you see here, this is the flap valve, the darker green portion is septum primum. If you visit the end pass view, or it's a septum as seen from the right atrial aspect, darker is the septum primum, and the lighter green is septum secundum, and you have a communication which is closed by the septum primum on the left-hand side aspect. If you look at this, it quite easy to understand the formation of a secondum defect. An ostium secondum defect is primarily a deficiency, true deficiency of the ostium primum, of the septum primum membrane. And larger the deficiency, the larger is the secondum defect. So if this secondum, the primum septum is absent, then you have a interatrial shunt in the region of the fossa ovalis, and depending on the degree of the deficiency, that dictates the size of the defect as well. Some cases you can have a defect in the superior limbic band of the septum secundum, and this results in a very high secundum ASD. So in these cases, the secondum ASD will be much closer to the SVC, to the roof of the atrial septum, and would not be centrally located in the fossa ovalis region. But again, they are to be differentiated from the sinus venosus ASD, because there would be a little part of the septum secundum from the roof, which would be its superior margin. So if you look at this secondum ASD, you would see that the anterior and superior part of the septum is adjacent to the aortic sinus, the right sinus of Valsalva, and the inferior posterior margin is adjacent to the IVC. And so that is the basic understanding of the ostium secundum ASD. In cases where the mesenchymal cells do not migrate from the septum primum to join the endocardial cushions, the ostium primum persists as a permanent defect, and that is, as you know, all is associated with defects of the AV valves, the endocardial cushions being the mainstay of the AV valve formation. So in conditions where there is less juxtaposition of the appendages, the septum secundum does not form down, because the normal invagination of the atrial roof does not occur, and so you have an ostium secundum defect associated with conditions where there is a left juxtaposition of the atrial appendages. So if we look at the defects in the region of the fossa ovalis, they are the PFO and the ostium secundum ASD. Now, like I said, the PFO forms about 25 to 30% in the adult population, being quite common. And it is not a actual defect, but a potential opening, being a flap valve. And conditions that alter the atrial geometry in terms of distending the atrium, or conditions that increase the pressures in the atrium, can prevent apposition of the septum primum with the septum secundum, resulting in persistence of the foramen ovale. And these are conditions that you see generally associated with mitral valve disease, or left ventricle, any conditions which causes left atrial or right atrial dilatations, as in pulmonary hypertension, cardiomyopathies, and left ventricular diseases. So the defects located away from the fossa ovalis, here comes the sinus venosus defects, the SVC and the IVC type. These are basically due to deficiencies in the formation of the wall between the SVC and the right upper pulmonary vein in case of SVC type sinus venosus ASD, and deficiency in the formation of the wall between the IVC and the right lower and middle pulmonary vein in the case of IVC type sinus venosus ASD. Ostium primum ASDs are much closer to the AV valves, and they are caused by deficiency in the migration of the mesenchymal cells from the ostium primum to meet with the endocardial cushions. So you have a defect which is located quite inferiorly and adjacent to the AV valves. Coronary sinus defects are quite uncommon, and they are usually located posterior inferior to the fossa valis region. On the right atrial side, the location would be where the coronary sinus opens into the right atrium. And on the left atrial aspect, this defect would be just adjacent to the posterior medial valve of the mitral leaflet, posterior medial cusp of the mitral leaflet. And very commonly, this could be associated with a persistent left SVC to the roof of the left atrium. So in that case, you would have a left to right shunt at the level of the coronary sinus defect and a right to left shunt at the level of the SVC LA junction, LSVC LA junction. And there is a specific name for this syndrome. Can you name that? A condition where unroofed coronary sinus is associated with a persistent LSVC to the roof of the LA. What is that? Raghib syndrome. That is correct. So that is Raghib syndrome, where the unroofed coronary sinus is associated with a persistent LSVC to the roof of the left atrium. And it's worth, when you see a condition like that, it's worth looking at the abdominal situs and the spleen to make sure many of these conditions could be associated with polysthenia and could be heterotaxy. So looking at the natural history of ASD, spontaneous closure of ASD occurs in approximately 80% of infants and in 25% of children when the defect size is 6 millimeter or less. So when you see an ASD soon after birth and it measures 3 millimeter or less, generally we do not recommend a follow-up for that because these would invariably close spontaneously. But if they are more than 8 mm, then a follow-up is warranted. And if they are beyond 10 mm, they are unlikely to undergo spontaneous closure. Some of these defects between 6 and 9 mm can exhibit regression in size as the child progresses from infancy to childhood. And about 30% of the large defects may increase in size as the child grows. Now, I would like to draw your attention to this nice paper from Mayo Clinic, which was Mayo Clinic, which was conducted, where they studied about 123 patients who underwent surgical repair of isolated secondum and sinus venosus ASDs between 1956 and 1960. And they followed them up at 27 to 32 years post surgery. And the findings findings were that the 30-year overall actuarial survival rate among survivors of the peri-operative period was 74% in the operated group as compared with 85% among controls matched for age and sex. So that is quite a significant number. The actuarial 27-year survival rate among patients in the younger two quartiles. These 123 patients were divided into four quartiles of less than 11, 12 to 25, 25 to 26 to 40, and beyond 40 years. And what they found was that the actuarial 27-year survival rates among patients in the younger two quartiles, that is the less than 7, 11, and 12 to 24, were no different from rates among controls. It was 97% for those in the less than 11-year age group, and 93% for those in the 12 to 24-year age group, and there was no difference with the control group. And in the older quartiles, the 27-year survival rates were significantly less, 84% for those in the 25 to 41-year age group as opposed to 91 in the control group, and 40% in the above 40 group as opposed to 59% in the control group. So this clearly lays the case for earlier closure of atrial septal defect. And the independent predictors of long-term survival, according to multivariate analysis in this study, was the age at operation, and the second determinant was the systolic pressure in the main pulmonary artery before operation. So clearly, it augurs well for the patient to have an atrial septal defect diagnosed early and closed at least below 25 years, if not earlier. This is another paper which studied the pathophysiology and natural history of atrial septal defect. When unoperated, they found that there was quite a significant increase in the mortality and morbidity factors. There was not much of a change in the impaired exercise capacity, but as you can see, there was a significant increase in the arrhythmias, in the pulmonary hypertension, in heart failure, and mortality. And this is not surprising considering that in humans, volume-induced RV hypertrophy substantially decreases the coronary reserve. So again, unoperated ASD can lead to a significant mortality. Now, we need to look at the factors accounting for the left to right shunt. Primarily, if we look at the factors, it's the size of the defect and the relative ventricular compliances. And the relative ventricular compliances play a large role immediately after birth, and also in old age when the ventricles are subjected to some form of restriction or disease. So after birth, when the immediately after birth, when the RV compliance is low and the pulmonary vascular resistance is high, the shunt, the interatrial shunt from left to right is significantly less. And as the pulmonary vascular resistance falls and the RV compliance enhances in the subsequent weeks of life, the left to right shunt across the interatrial septum enhances. Size of the defect also is a major factor in dictating the amount of the shunt. The other factors are RA being more distensible than the LA, the tricuspid valve being more capacious than the mitral valve, thin-walled RV being able to accommodate more blood volume than the LV, and of course respiration, which during inspiration there is an augmentation of the right side filling as opposed to expiration when there is less. shunt. Uh, there's obviously no left atrial enlargement because blood does not stay in the left atrium. It's immediately shunted into the right atrium, so there is no left atrial enlargement. But with a sustained large shunt over a period of time, there is enlargement of the right atrium and the right ventricle. Um, so unless there is pulmonary artery hypertension, there is no associated wall musculature hypertrophy in this. Usually, hypertension kind of sets in the third decade, and that's when wall hypertrophy is noted in the RA and RB. Otherwise, below 30, below the third decade, you just see the enlargement and not the uh, hypertrophy. And chronic sustained interatrial shunt left to right produces what is called the reverse Bernheim's effect. So here I would like to ask you, what is Bernheim's effect? You have to know what is Bernheim's effect to know what the reverse is. So my question is, what is Bernheim's effect and what condition does it allude to? So what is Bernheim's effect? We lost connection. It's basically uh, 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 what you see in severe aortic stenosis when the hypertrophied interventricular septum bulges into the right ventricle during diastole and compromises the RV filling with consequent right ventricular failure. So it is a left ventricular disease which affects the right ventricular right ventricular filling and causes right ventricular failure. And so what happens with the ASD and the chronic shunt, left-right chronic shunt is a reverse Bernheim's effect, where the right ventricular filling is enhanced, and that pushes the interventricular septum into the left ventricle during diastole, compromising left ventricular filling, and can result in left ventricular failure effects. So in echocardiography, you would see this as a D-shaped left ventricular morphology during diastole, and in a cross-sectional view, and during systole it would assume a circular shape. So this is called the reverse Bernheim's effect, and usually is seen with chronic shunting in a large atrial septal defect. So So that is one of the reasons why when you have a stiff left ventricle, you could have, when you do a device closure, you can have left ventricular uh, increase in the end diastolic pressure and acute pulmonary edema. So with a sustained large left to right interatrial shunt, going beyond the third decade, the earliest lesion which you see in pulmonary artery hypertension is cellular fibrous intimal thickening in the proximal segment of the arterioles. and subsequently medial hypertrophy of the arteries and appearance of plexiform lesion. Now, running through the symptoms, you have exertional dyspnea and fatigue is the predominant symptoms. And later on, with sustained shunt, you can have palpitations, syncope, and stroke arrhythmias setting in. If you look at the signs, there is a clinical examination would show a mild right a precordial bulge and an RV systolic thrust all along the left sternal border. S1 may be slightly accentuated due to tricuspid valve closure being loud. S2 is wide, fixed, and split, and occasionally there is a soft systolic ejection click heard in the lower left sternal border. The P2 tends to be accentuated even in the absence of pulmonary artery hypertension. And among the murmurs, you know that the shunt per se does not cause a murmur. The murmurs are due to flows across the tricuspid valve and the pulmonary valve. The pulmonary valve ejection systolic murmur being the more prominent of the two, and a early diastolic murmur being the flow across the tricuspid valve. If you hear a harsh murmur with a grade 4 over 6 or beyond with a ejection systolic click and a precordial trill, then an associated pulmonary valve stenosis is to be suspected. Like I said, there would be a soft systolic click along the lower left sternal border associated with ASD. Sometimes you can have a mid-systolic click along the apex, and when combined with the pansystolic murmur can indicate mitral valve prolapse, or when it is associated, when these findings are associated with holodiastolic rumble and an opening snap, then an associated mitral stenosis or Luton Backus syndrome should be. Now, if you look at the second heart sound, which gives a clue to the ASD in most of the cases during auscultation, you would find that the normal second heart sound is kind of fused during expiration and split wide during inspiration, whereas in ASD they are fixed. Now, we need to understand why this happens and to be able to understand the reason behind it happening in a atrial septal defect. So, what are the factors contributing to a S2 split in a normal heart? There are three main factors. I would like you to list them. The most important one as the first one. Hangout interval. That is correct. So hangout interval is what contributes most to the S2 split in a normal heart. The other two being the inspiratory prolongation of RV systole, which contributes about 25%, and this delays the T2 part of the second heart sound, and inspiratory shortening of the left ventricular systole due to pooling of blood in the pulmonary venous circuit, hastens aortic closure, and so that contributes 25% to this. Hangout interval is what contributes most to the inspiratory to the S2 split in a normal heart. And what is the hangout interval? It's the time lag between the closure of the semilunar valves and the pressure drop in the ventricle and the outflow tubes. So compared to the left side, the hangout interval on the right pulmonary valve is much longer, about 60 milliseconds uh, later than the aortic hangout interval, which is about 10 milliseconds. So what happens is, yes. Uh, so what happens is the semilunar valves close much later uh, uh, than when the ventricular pressure drops below that in the outflow tubes, with the result that blood continues to flow into the pulmonary circuit much longer than into the aortic circuit, mainly because of the impedance that is seen in the left and the right side. Impedance on the left being the systemic vascular impedance, which is higher, and the pulmonary vascular impedance being lower, encourages longer hangout interval on the pulmonary side. So the factors contributing to a wide and fixed split S2 in ASD is the loss of respiratory variation that normally occurs in a heart with an intact interatrial septum, and enhanced pulmonary venous compliance, which is seen in a chronic shunt where the pulmonary vein, the venous circuit dilates and becomes more compliant and holds a larger volume. So coming to the investigations, ECG, we look at the rhythm, usually sinus rhythm, and with age, sometimes you can get intra-atrial reentrant tachycardia and atrial fibrillation. 6 to 20% have first degree AV block, and commonly a right axis deviation in older children and adults. And the QRS configuration shows an incomplete right bundle branch block. Atrial enlargement can be seen in right atrial enlargement in about 35%. Ventricular hypertrophy is uncommon. And there is a specific pattern that is seen in ECG of these patients, which can point to the underlying pathology. Can you name that? There's a specific sign called the specific sign. What is that? Crochetage sign. Yeah, that's correct. So crochetage meaning it's a French word which means a notch near the apex. So which means a notch, and you normally find a notch near the apex of the airway in the inferior limb leads. Usually, this sign would disappear 2 weeks after the interatrial shunt is interrupted. So this is an ECG of a patient, 40-year-old with an ASD, and you can't see the crochetage sign very clearly here, but you see it in this cartoon with an ECG where you see it's a notch near the apex of the airway in the inferior limb leads. Coming to the X-ray, again, the cardiac spillout is typical in an ASD. You can see right atrial enlargement. So you see pulmonary artery dilatation and mildly increased pulmonary vascularity on both sides. As you can see, the LV contour is normal. So, being pediatric cardiologists and being eager to close many of these holes, it's important to know the margins so that you are able to assess by echocardiography the suitability of the defect for device closure versus non-device closure. By virtue of the position of the secondum defect, the superior anterior margin is adjacent to the right sinus of valsalva here, and the posterior inferior margin of the defect is close to the IVC. You have the mitral margin, which is close to the mitral and tricuspid valves inferiorly. The superior margin, which or the SVC margin, and the posterior margin, which is the margin from the defect to the posterior wall of the atrium. So it's important to assess all these 5 margins in great detail to be able to decide on the subsequent management of a ostium secondum ASD. Now, echocardiography plays a great role in diagnosis as well as determination of the type of morphology of the ASD as well as the size and the shunt. Um, this is a subcostal view of which shows the ASD subcostal left anterior oblique view, where you can see the liver here, the left atrium and the right atrium, and the defect is profiled well. You can see the margin, XCC margin, and all profiled very clearly in this. There is a four-chamber view, which again shows you the defects, and then the parasternal short axis view, where the aorta short axis view, where you see the anterior and the posterior margins of the defect clearly seen. So transthoracic echo provides a great deal of information as to the morphology of the defect, whether it's suitable for device. And here you see a subcostal view which shows a coronary sinus defect clearly profiled here. And this is an transthoracic echo image of a IVC type sinus venosus defect. As you can see, it's located quite posterior inferior, and practically no IVC margin. And transthoracic costal view of SVC type sinus venosus ASD. So majority of the times these are sufficient, but when you have complex ASDs and much larger ASDs, or in patients where transthoracic echocardiography is not optimal, then you resort to transesophageal echocardiography, where you mainly use three views. The 0 degree or the transverse view, which shows you the anterior and posterior aspect of the defect. Here the probe is kept at the mid-thoracic level and rotated right and left to get the anterior to posterior. As you can see in this panel here, the probe is higher up, and you see the aorta and the left atrium here, the right atrium here, and the septum is intact here, which means the defect is not formed at that point. And when you bring it to the mid portion, you see the defect forming here. And when you again bring it lower down, where you can see the AV valves, the septum is formed. So this is a nice central defect, which is seen here. And here in panel B, you have the 90 degrees view, which is a good view to assess the SVC and IVC margins. And the 45-degree view gives you a good idea of the aortic and the margin and the posterior margin. Now, Balu Vaidyanathan in this paper in the JAC has described some special views to look at the IVC margin, which is not normally well seen with transthoracic echocardiography. And he has described the retroflexed view, where the probe is pushed into the stomach. The transesophageal probe is pushed into the stomach, and then is pulled up slowly along the esophageal, along the gastroesophageal junction up, and that puts the IVC margin in perpendicular to the probe and gives a view of the IVC margin here. This is not seen in the conventional transesophageal view because of its proximity to the esophagus. So you take the probe into the stomach, retroflex it, and then bring it slowly up towards the gastroesophageal junction upward, and that shows you the IVC margin. So that is about the transesophageal echocardiography. This is an image of the three-dimensional images acquired during transesophageal echocardiography, which can give you a good idea about the morphology of the secondum ASD, and if there are multiple penetration morphology of each of these to determine whether they are suitable for multiple devices to be used closure or to go for surgical closure like what is done here. And this is my last slide. This is an intracardiac echocardiography called ICE, which is used for well, visualizing the atrial septal defects in some complex cases. And you have multiple views here. This is the panel A shows the home view, and panel B shows you the long axis view, and C shows you the bicaval view. And here is a short axis view of the septum, atrial septum, which shows a small PFO, a short axis view of the septum, which shows the atrial septal defect. So this is used in some centers, but majority of the time you don't need these advanced imaging techniques. As you get more and more experienced, you are able to close many of these defects very successfully with just transthoracic and transesophageal echocardiography. So that brings us to the end of this presentation. I wish you all the very best and very happy New Year again. Thank you. Savita, can we end this?